So really briefly, Dr. Teresa de Moral is currently at the University of Miami in Florida and has done a lot of great work throughout Latin America and South America, Central America, around neonatal resuscitation. And I was just learning as well around kind of networking for neonatologists and building communities of neonatologists in the Dominican Republic and Colombia as well. And then Dr. Yasser Arain is a neonatologist in private practice currently. So I think it'll be really interesting to get that perspective, and has spent time working abroad in the Middle East, and then doing some political advocacy here in the US. And so excited to hear from your experiences and perspective as well. And then Dr. Manish Batra is a neonatologist in Seattle, Washington, at the University of Washington in Seattle Children's, and has extensive experience working in Kenya and Uganda, and elsewhere, as well as consulting for the WHO and the Gates Foundation. Um, and so we are super excited to hear from all of you. Um, okay. I had some polls that I had made just to get to know the attendees, but since there aren't that many of us, I'm wondering if maybe the attendees want to just quickly introduce themselves also. And I can start. Sorry, I just realized I never introduced myself. I'm Hannah Sheikh. I am a second year NICU fellow at the University of Washington. So I'm lucky enough to get to spend some time with Manish. And let's see, I did a global health fellowship through the Children's Hospital of Philadelphia in the Dominican Republic. So I was chatting with Teresa about that. And then have done a little bit of work in Tanzania with Shannon. So it's exciting to see you on this call as well. And then have most recently been working with Sarah and a group of other NICU fellows to kind of provide a network for trainees and early career folks, nurses, et cetera, who are interested in doing neonatal global health work, just so we can learn more about how to delve into this space and do productive work in this space. Um, Sarah, do you want to introduce yourself
Mhm.
really quickly?
Yes. Hi, everyone. I'm Sarah. I'm a second year neonatal fellow at University of Miami. So I work very closely with Dr. Damaral. I am originally from Pakistan, and that's where I did my medical school. And I'm working closely with our neonatal care in northern Pakistan. So that's how I got involved in global health. And like Hannah mentioned, recently we've been working together on a global fellows group, and it's been great working with her. So yeah, I'm happy to be here.
Mhm. And Sarah's been kind of spearheading a packet of resources for that will be easily accessible for, so just like a Google Drive of resources that many of us are kind of lucky enough to be on the correct side of the paywall for. So to kind of help make things available for our colleagues in countries abroad. Um, Shannon, do you want to introduce yourself?
Yeah, sure.
Mhm.
Hi, good to
Hi,
see
it's good to
you.
see you.
My name is Shannon. I'm a NICU nurse in Southern California. I got into the global health space in 2022. I went with two of my colleagues, two of our clinical educators, to Tanzania to teach at a neonatology conference, and that was where I met Henna. And I've been going back the past few years, so that's kind of how I got into it.
Mhm. Michelle, do you want to introduce yourself if you're in a place where you can speak? And if not, you could just type in the chat. I wonder if she's not in a place where she can unmute and chat, but maybe Grace, do you want to introduce yourself if you are?
Hi. I'm a first year medical student at the University of Kentucky. I don't have much experience with neonatology, but I am also very interested in neonatology and in global health work. So I kind of wanted to just see what the research is about and things that are going on in that field.
Cool. Thanks for joining. Exciting to have you. And very excited to hear that you are thinking about neonatology. We'll hope that by the end of this that you're even more excited about it. And then I also see God Bless has joined. Welcome, God Bless. Do you want to introduce yourself really quickly? We figured since there aren't that many of us, we would just go around and introduce ourselves.
Yes, sure. My name is God Bless. I'm currently in Arusha, Tanzania. I've been working in NICU here in Tanzania for the past 4 years right now, and I'm currently an incoming pediatric residency at University of Minnesota and also planning to do NICU fellowship afterwards. And also interested with global health and neonatology and research.
Yes, God Bless is one of the star pediatric registrars at the NICU in Arusha. And so Shannon and I have been lucky enough to meet him there. So what a great crew. Well, thank you all for joining. Okay, so without further ado, we will let our panelists take it away. And so Teresa, if you want to start by kind of sharing your segment, and then we'll have Yasser share his segment, and then Manish, and then we'll have some time for questions at the end. And if any questions come up kind of while people are presenting, please feel free to put them in the chat, and then we can ask them at the end. Oh, wait, we can't hear you. It doesn't look like you're muted.
Oh,
There we go.
you me the first.
Is that okay?
Yeah.
Okay.
No, I thought I didn't understand that. Yeah, I didn't hear that. So, I mean, you give us a guideline of what to talk about, and then so what the unique aspect of my path to global health, I think. I mean, probably there is many things that are unique. I think one of the things that I mentioned before is the fact that trying to balance between being an intensivist and then what looks like the other extreme of taking care of people or something, which is the preventive medicine. So that at one point in I think I was already working in Spain. I saw that, and then I decided to do a master in public health, which at that point, now it comes together. So many students, they go the master in public health all together because I think over time the people recognize that both things are important. But at that point in my country, there were no school of public health. And the only way to do it was in England. I mean, there was many, but the closest one was England. So I didn't do, but I started to be interested on looking at population, looking at things that impact, it might be impact the life of the population more than individual lives and everything. So then I moved to the States for different reasons. I came to do 1 year and I stay here. And then I have a public health school right across in the next building. And then I took advantage of being on maternity leave to go to did a master in public health. And then I think what had guided my prevention strategies or prevention idea is the fact of I always was fascinated, and I became a neonatologist because I was fascinated with to be born, with the physiologic, but at the same time, more drastic changes in our life, which is to be born. So in a few minutes, a person who is completely dependent become independent and everything. And tied to that is the fact that anything that you do that, I mean, mortality or infant mortality has a good proportion of babies who die in the first 24 hours, which is tied to the fact around to be born. So I always think that doing the right thing on those 10 first minutes of life may change completely the life of many people, even when we don't know how much. But so that idea is something that has guided my work as a neonatologist, and also my focus, or a little bit my focus on whatever global health I can do. So then, so that's the way that I became interested, but I became more involved in global health, just traveling. Like whenever you travel and whenever you go to another country, you see people ask questions, and then when you become interested, you see how much thing you can do. And I think one of the things that I felt when I came to the States is even coming, I was coming from Spain, but I was coming from a hospital that was in a very rural area that was completely not well communicated. So when I moved to the States, I thought that I had the feeling that everything was done here, that here there was people for everybody, and then the rest of the world was, I mean, on many other areas, there were so many things that needed to be done that I felt like doing a little effort, which is not true, but I mean, that is not a little effort, but doing things that you can change things very in many other places, in other places. And then one of my colleagues, which is Dr. Angelica Florent, she's from Dominican Republic, and she's always tied to Dominican Republic and trying to improve things and just traveling to other countries. So I started to teach neonatal resuscitation and many other things, because the neonatal resuscitation goes tied to the care of the premature infant and everything. And then, yeah, I mean, sometimes it's part of a program, sometimes it's in more rural areas, but at the end, what you try to do is to have them to take their own responsibility. It's not that you want to help them. I mean, you want to help, but you want them those to grow and to be the one that really move the things. So in terms of advice to the new people, I think, well, what I say, just traveling, going to the place, is you will get inspired. So whenever you go, you see so many things that you think you can do or somebody can do or needs to be done. The other thing is like you had to work from their own culture. Wherever you go, you had to understand their culture. You had to start from their own understanding of things. So, like we do or whatever it is, like, how can we do the things the way that you do, but try to optimize whatever you do. And I think one thing that is a little bit a challenge or has been a challenge is sometimes you had to, I mean, sometimes no, you're supposed to work with their own institutions. So it's not at the individual levels, but in many of these places, they have institutions, they have societies, or they have national health systems, so you had to also learn from them and work with them, with their own institutions. So through that, the teaching of the neonatal resuscitation, which, I mean, you can call it NRP, but sometimes it's not NRP because you start from a different place or two different things. So I had worked a lot with Colombia just because I met them and I had gone many times. And then what you learn is because you want them to carry their own thing. Is not, I'm coming to teach you, but just to make them able to teach themselves. So in Colombia, really is one of the places that they have taken over. They have, I mean, and now looking in retrospective, probably we started like maybe 20 years ago, but now they have their own system. They have developed their own book, which is obviously very similar and inspired in the American Academy, but they have their own tricks or their own things that are applied to their country, their area. In Dominican Republic is different. I mean, the people, I think in general, they're a little bit less advanced. So Colombia now, also after the political changes in Colombia, the thing became easier. And in Dominican Republic is the same thing. We are teaching, we started a national program. So collaborating with the national health system, we asked them to identify people from the 20 different hospitals that will cover 80% of the babies born in the country. So we were very excited, and then the pandemic came, and then we are trying to retake everything because the political changes now we are not where we were a few years ago. And then in terms of what's the rewardings, I mean, what I say, so now in retrospective, I look back to Colombia and I said, I see them moving by themselves and actually helping other people, because the people in Colombia now, they go often to Bolivia and other countries around. They try to reach rural areas. And what I say, like they teach neonatal resuscitation, but it's amazing because sometimes these moms to deliver, they just hang somewhere and then the baby's born and falls in something that I don't exactly know, that nobody will imagine, but anything. And I think the other thing that is very rewarding is that whenever you get to these places, or in general, you are very welcome, and it's very nice to see how interested the people is. And sometimes you go and then you spend the whole day and and then you say, well, we started at 8 a.m. and it's like 9 p.m. and we're still talking, discussing, or trying to learn. And just because you said that it was okay to see some pictures, I can share the screen. Can you see it? Do you see the?
We can see it, yeah.
Yeah, okay. I think I took the wrong one, but it's okay. Let me see. I start sharing. Let me see. My screen. Had too many. Maybe it's this one. Okay, yeah. I mean, what we were talking about. So this is, I mean, you say you had to warm the baby, and sometimes they don't have incubator for everybody. They don't have warmers for everybody. They don't have anything. So that's a challenge sometimes. So you had to work with whatever you have. I didn't invent this, but I saw this, and in some way, probably was better than to have the babies individually in warmers and everything. So how do I move this? Okay. So one of the things that we started in the Dominican Republic and has grown a lot is the mother kangaroo care. So we have at one point, I don't know whether if you are involved with kangaroo care, Nathalie Charpak is one of the promoters of the kangaroo care in Colombia. She's really a French neonatologist. And when she went to Colombia, the kangaroo care was like a rescue therapy, because I don't have an incubator. I'm going to allow or promote the kangaroo care, but the kangaroo care became the standard of care in Colombia. And I mean, the standard of care in Colombia, and everybody else in the world is imitating that. They are using the kangaroo care like a rescue therapy, like something that's supposed to be from the beginning. So the kangaroo care program in Dominican Republic was started like maybe 10, 12 years ago. And now it's also expanded we started with one of the hospital, and now it's expanded to many hospitals. And really, I think it has changed the life of many borderline premature babies. Obviously, the very premature baby, they need a different care, but they have, you see this, they have their own graduation. They have, I mean, this is the National Service, Health Service, Servicio Nacional de Salud. And so we have, I mean, beside the tops and everything, and we are learning of the kangaroo care program. We are trying to improve many things that still need to be improved. So the other thing was the neonatal resuscitation. And also with the neonatal resuscitation, obviously you have all the guideline or recommendation of the American Academy of Pediatrics, the ILCOR and everything. But then whenever you get there, for example, in many of the hospitals, they don't have air. So it's either room air or oxygen. They cannot mix. And I think this was developed by somebody in Boston, which is a blender, kind of a blender. So you can connect that, and depending on how much holes you have there, it will mix the air with the oxygen. So those little things are very helpful for many of these situations. So the other thing is that the important thing is not to teach, but just then to learn to how to teach. So this is teaching the trainers. You see, these are boxes that we develop with equipment for them to teach. So this was when we were doing the 22 hospital in the country with the 2 providers that will teach other people. We gave them all the kind of basic instruments to teach neonatal care, delivery room. And also another thing was the introduction of CPAP. And that was interesting because we just bought one Pumani. I don't know whoever you are familiar with the Pumani, which is a CPAP equipment that it has a blender. So we bought one, and it has a lot of publicity, or for whatever reason, the baby actually was the mother of Eliana, the model, the one that used the Pumani. And then there was another, I think it was USAID or another of this big foundation that gave 20 Pumanis for the whole country. So now most of the people, most of the hospital, they have access to the Pumani, so to CPAP. And this is a different CPAP. This is the bubble CPAP. And we were also teaching that last year. And so there are many things that you can do. You will see you don't see the results right away, but whenever you look back on retrospective, and I am looking to all of you, and you look younger. So if you are persistent, years after a few years, you will see the difference and the impact that that relationship with those areas can have in the life of these babies. And yes, this is just the latest one thing. This was in Bolivia, and the same thing is the work of many years. So I mean, there is a huge amount of babies that are born in the altitude, like about 3,000 meters. And obviously the growth, the being born, the pregnancy and everything of these babies is different, and it has a lot of impact in the long term. And really, whenever you look at the literature, there is some literature, but not too many things or not too much of what to do. So after a few years working with a colleague of me, which is a fellow that is from Bolivia, this year he came up with this thing, which is he's getting the foundation for babies born in the altitude. And there is a lot of people involved from Europe, from Canada. So, I mean, you will be welcome also to know about this foundation. And that's it. If you have any questions, we will have the question later.
Thank you so much. That was so inspiring, and really nice to see the pictures also of some of the things that you've some of the people that you've worked with, and some of the babies that you've worked with, and the things that you've been able to do. Thank you for sharing that. I think if it's okay for timing, we'll save questions for the end, and maybe we'll move on to Yasser, if you want to share kind of your path to where you are now. And welcome to the new folks who have joined us as well.
Yeah, sounds good. So I'm just gonna go through my presentation that I put together a couple days ago. All right. Yeah, so my path towards global health is a little bit unorthodox. So just for people who weren't here when I introduced myself, my name is Yasser Rain. I'm a neonatologist. I'm 7 years out of fellowship. I did global health work during residency, but my path, I'll talk about it a little bit, was predates that. And I've sort of jumped back into some endeavors that are abroad more recently, and I'll talk about that as well. But I'm an attending, I work in private medicine. I work for Pediatrics, which is a large private group in the United States. But I do work at Cook Children's, which is a level 4 in the greater Fort Worth area. And I am faculty at Texas Christian University. I'm an assistant professor there. And but you know, for the most part, I'm coming from a different perspective than my esteemed colleagues on this panel. So my global health path, let me see if I can, sorry, let's see. All right. My global health path really began in 2007 when I was an undergrad. After I graduated from getting my bachelor's, I did a year abroad in Cairo, Egypt as a Fulbright scholar, and I focused on forced migration and refugee studies at that point. At that, it was 2007, 2008. There were sort of a mix of refugees in Cairo. I think there were about 30,000 at that time. And and they were coming from different places, some from Somalia, some from Sudan, and others from Iraq. Um, and at that time, I partnered with local NGOs to do health assessments, essentially to help them figure out exactly where to allocate their monetary, funding, and where it could have the most impact. And then I also spent some time taking some courses at the American University of Cairo on forced migration and refugee studies. But probably the most seminal, experience that I had was actually when I went to a conference in Jordan that they had for all the Fulbright students and scholars in the Middle East, North Africa area, and took an adventure to Palestine. And I spent 48 hours there, and it really changed my life. And things sort of come full circle. So when I started residency after medical school, I did the global health track at Stanford, which was cool because it had formalized educational courses. They had a mentoring structure in which I could talk about, how to approach global health from a perspective of, again, empowering those abroad, and if there was any way that I could benefit them with the skill set that I developed in the United States. And I did receive something called the Mary Duke Biddle Scholarship to do global health. To do a global health project essentially. And I partnered with Dr. Eric Nelson, who's now based out of Florida. I think he's at University of Florida. Um, and he just let me tag along with him actually and sort of troubleshoot some informatics type of projects in Dhaka, Bangladesh. And our goal at that point was to see how we could use modern technology, drones and other types of technology to improve access to medication and other care in some of the more rural areas of Bangladesh in general. And that sort of segued into my other interest, which is clinical informatics. So that was my experience during residency and fellowship. I didn't really do much, to be quite honest. I was so busy with informatics projects. The most productive thing I did for global health was I was uh, authored this paper on the prevention of connectors in South Asia and talking about screening practices for G6PD deficiency. And for those, I'm sure many of you know, it's G6PD is very common, and it's the most commonly inherited disorder in the world, and it disproportionately affects Asian populations, Southeast Asian populations, and the Middle East. So I didn't really do much, and then. I spent my time developing this. So Preemie Billy Rex, if any of you guys have used it, was my main project during fellowship. And now, I tailored it so that as we were developing it, I tailored it so that we could use it abroad and have it applicable sort of anywhere. And so that's like a small indirect way, I guess, of doing global health. Again, sort of stepped out of the space. I wasn't really engaged. And then I became a dormant attending. I started off at faculty at UC San Diego, and then for family reasons, moved back up to the Bay Area and was working at a county hospital, Santa Clara Valley Medical Center. And I was a professor at Stanford at that time as well. And then decided to make a move to private medicine for various reasons, and ended up in Dallas, Texas. And it's been a blessing. So I work for, like I said, pediatrics, which I'm sure many of the American folks here have probably heard of that group. Um, and my life changed in 2023. So when the attack on the healthcare system in Gaza started happening, mostly in November and December of 2023, after October 7th, I felt compelled to do something. And I think I probably speak for my colleagues here and for anybody that has done global health work. Oftentimes, whenever you engage in any sort of activity in that regard, like you benefit more than you contribute. That's how I feel, and that's how I continue to feel. But I was inspired to at least physically do something. And one of my best friends in medical school had gone to Gaza, and hearing about his experience, and he worked with IMG and built a field hospital, and worked as an emergency room physician there. I just had to go. And I think, for modern warfare, this is a sort of a new precedent that's been set in terms of the attack on healthcare workers. And once, that stuff is normalized, attacks on hospitals, targeting physicians, nurses, and other healthcare workers, it sets a bad precedent for any future warfare, regardless of where it occurs. And I wasn't surprised that, a couple of weeks ago, we heard about a hospital in Sudan that was purposely bombed and destroyed. And so I think we're going to start to see this a little bit more. And it took something like this to sort of wake me up in terms of like, what was I doing with my life? I live a very privileged life here in America. I've been able to benefit from some of the best neonatology mentors that exist in this world. And I felt pretty, I don't know, selfish and not taking advantage of the opportunities that lay ahead of me. So the next question I asked was, how can I get to Gaza? And thankfully, I live in Dallas, Fort Worth. There were several physicians in my community and even in my neighborhood that had gone to Gaza and were in the process. And so I was able to partner with this organization called Palestinian American Bridge, or PAB, that was headed by Dr. Akram, who is an adult physician based out of Houston, who is actually from Gaza itself. And he had this organization that's been around for a couple of decades, but very, quiet organization. They don't fundraise loudly. They sort of do small operations. But he was a segue. He provided the opportunity for me to go abroad. They needed a neonatologist. Apparently, there had been no American neonatologists that had gone to Gaza for any of the medical missions since October of 2023. And so I was able to go in April of 2024. And I learned a lot about, in terms of whenever there's a conflict, a violent crisis, like how do medical missions work? What's the process politically? What's the bureaucratic, hoops you have to jump? And it turns out that the UN and the WHO were organizing a lot of these missions in regards to the paperwork. So, finding out who's going, getting approvals, passing that information on. In this scenario, to Israel, Israel has an administrative branch called COGAT, COGAT, that supervises all the aid that's getting in, or in this case, not getting into Gaza. And that's how the bureaucratic principle works. And the crazy part is that, like, oftentimes, you see physicians or surgeons that are going to Gaza, they're not finding out if they're getting in until the day before, or sometimes the day of that they're supposed to go. So you have a ton of people from the West. As we know, like, it's hard to get vacation time. It's hard to get time off or blocks of time off, especially if you're not in academia. Even in academia, it's tough. But then you go, you fly, you get to the place that you think you're gonna go help, and then maybe you just get turned away for no reason oftentimes. And it really opened my eyes to how toothless and helpless actually a lot of the international organizations that we look up to are, because they can't really enforce anything. They can't enforce humanitarian aid. They can't enforce um, uh, any approvals on behalf of physicians or anything like that. And so the levels that you have to jump through and hoops that you have to jump through to do what you think is good work, it was really disheartening, to be quite honest. But anyways, thankfully, I got to Cairo. This is in April of 2024. And we crossed through the Rafah border. And it just so happens the Rafah border borders the Sinai Peninsula. So all medical missions were going through the Rafah border. You would land in Cairo, you would make a 4-hour drive with the coalition of UN buses, and you would get to the Rafah border and you would cross through there. And it just so happens that May 6, 2024 was when the Rafah border was destroyed. So exactly a year ago it was destroyed, and there has not been any medical aid that has gone through there since. Um, and then it's like, what do you expect? You're a neonatologist. I'm not a surgeon. I'm not doing plastic surgery, trauma surgery. I'm not doing general surgery. Am I helpful? And to be quite honest, a lot of the subspecialists that exist in Gaza had either died, been killed, or fled prior to April of 2024. And so when I landed there, there was no neonatologist in Gaza. There was One higher level, I would say it's kind of like a level 2+3+ NICU that existed. The other ones had been destroyed. And that's sort of where I made my home, and that was in central Gaza. But when you go there, like I'm in private medicine, I can round on a bunch of babies like very fast. That's all I do is clinical medicine. And so the question is like, what else am I going to do with my time? Um, and I realized that in a war zone, essentially you fit in wherever you can. And so I was taking care of babies, I was taking care of toddlers, children, adults that came through the yard through mass casualty events, and just doing what I could. I went with a bunch of surgeons. Sometimes I would, you would scrub in and just be their scrub tech, shoot X-rays. You just do whatever you can. The other thing is I use sort of my brain power to do some of the other work that, the local doctors and nurses and local people, don't have the capacity to do when they're in pretty much survival mode and fight or flight. A lot of the administrative stuff, the forecasting, the planning, it falls to the wayside and fell onto a lot of the aid groups that had been sending in workers. And so one of the other things that I spent my time on was answering the question of what's salvageable. And so we would go to different medical centers that had been either occupied or destroyed by the Israeli military to see, well, what can we reopen? If you know the Palestinian mindset, they're very resilient people. And they're always asking, okay, this is destroyed, but what can we do about it? How can we move forward? And so that picture on the very right is from Nasser Medical Complex, which is now up and running actually. But at that time, I had gotten there about 1 to 2 weeks after that the Israeli army had evacuated it after they occupied it. And we were trying to open up a physical therapy clinic. And so we came across, that place that was honestly, it's not even the worst picture. I just wanted to show something that just shows, sort of like the mess and sort of deliberate destruction of medical supplies. And now that place is up and running as a physical therapy center for many of the child amputees that exist. The other question is like, where are you going to sleep? Sometimes the WHO had designated safe houses, but these safe houses had been bombed before and they were sometimes targets. And so we, as a group, decided to sleep in the hospital, just slept on the floor for a couple of weeks. There was like 25 people sharing one bathroom. But we were blessed to have a roof over our heads, to have a functioning toilet. It was a luxury at that time. And it was some of the best memories I've had. Um, the child on the left is just an example, for anybody that's been in neonatology for so long, like I already felt like I forgot a lot about pediatrics. But that's just an example of some of the patients that we were seeing, that I would weigh in on my medical opinion, because to be quite honest, like a lot of the doctors that had experience would have probably had some money and were able to leave before things got really, really, really bad. And so you have a lot of junior doctors that were left over, ER doctors or doctors straight out of medical school that are treating all kinds of patients. And so any expertise that I could lend, I did. And this was all in the setting, 24/7 drones buzzing overhead, bombs that were shaking the buildings. Sometimes, we would hear sound bombs just to terrify the civilian population at 2 or 3 in the morning. That would wake everyone up. And it was just, it was a pretty terrifying environment. And I think, it's still not over, but there's a lot of trauma to be dealt with, I think, post-traumatic stress disorder for not only the native population, but a lot of healthcare workers too. The other, from a NICU perspective,
Sir, I'm so sorry. I just wanted to, this is like so amazing and so inspiring and just like so powerful to hear about all of your experiences. So thank you so much for sharing. I wish we had like a whole day to, or like multiple
sorry,
days to
yeah,
talk
I
about
can
this.
go.
But do you mind just kind of yeah, I'm just looking at the time and wanting
Yeah, I'll go fast.
Okay,
Yeah,
thank you so
no problem.
much.
Okay, so a lot of the NICU stuff was spent triaging patients. So this is a 25-weeker that came in. This NICU only had 4 ventilators, so didn't have TPN. So we weren't gonna expend a ventilator for this child who was likely gonna inevitably die regardless. That's the mother. She was the only surviving member of her family. And so we try to keep the baby alive enough for the mom to see. And the baby died about 2 weeks later. The other aspect of my time there was spent doing human rights work. So I got contacted by some lawyers from the ICJ and ICC from South Africa, who asked me to gather any evidence of any war crimes that I potentially saw. And so that was sort of the other hat I wore, was just being a journalist. I'll play this video really quickly. This was the first patient I took care of at Al-Aqsa Hospital. Assalamu alaikum, Mustafa. All right. So right here, this is an entry site for a gunshot wound. On the other side, the exit site. He was shot by a quadcopter controlled by the IDF while breastfeeding with his mother. So yeah, so that's baby Mustafa. He's now a year old. He was shot while breastfeeding. This is his mom in the tent that she was holding him in. And one of the things that they asked me, one of the things that they asked me to do was to get justice for Mustafa and his family. And I told him I could only do what I could, but I was able to do some journalistic work, get evidence of the bullet shells, exact location from GPS, had the dad shoot some videos from eyewitnesses to give testimony as to what happened. And that's now part of the ICC case. And then when I came back home, a coalition of me and about 80 other doctors and nurses formed this organization called Healthcare Workers for Humanity. We did some advocacy work on the Hill, met with over 100 senators and House of Representative members to advocate for aid to increase. And then briefly after Gaza, I went to the West Bank to do NICU surveillance. Again, more advocacy work with the Palestinian government in terms of allocating more resources to neonatal care and talking about how that has long-term impacts on how society develops, sustains itself, and grows. And then in East Jerusalem, I worked with JHPAGO, Heal Palestine, and USA to do a week-long educational course for the neonatologists and neonatal fellows that they had there. And that's basically brought me to here. So just FYI for the people that are thinking about going into neonatology, when you work for a private employer, you usually have to, don't expect it to be part of their overall mission, global health work. Expect to use vacation time on your own and to be willing to sacrifice that. But then the way that you can sort of mitigate expenses and whatnot is by partnering with local NGOs that will pay for travel expenses, facilitate organized projects, and allow you to have some creativity in terms of how to partner with local experts. Thank you. And then this is Dr. Thabat Salim. I just wanted to put her up here. She's a dear friend of mine. She was killed in January when she was changing dressings for her family. And that building was targeted and killed. She was a promising young neonatologist. So if you want to contact me, that's my contact. I have more documentation of sort of my experiences at Gauze for Gaza on Instagram. Sorry for taking so long.
Don't apologize. It's my fault for asking you to talk about such an important topic in an unreasonably short amount of time. But yeah, thank you so much for the work that you've done and for sharing a little bit of your experiences. Super powerful and impactful and such a poignant example of the ways that we can, be helpful by just jumping in and responding to that voice inside of us that tells us that something isn't right. So thank you so much for sharing that. Okay, we'll pass off to Manish to talk a little bit about your path, and then we'll have some time for questions after that.
Thanks, Hannah. It's a tough act to follow. Really inspiring and moving words and stories. Thank you for that. I'm also moved by the range of participants, from students to fellows, nursing. Very cool. Okay, now I can share. Oops. Sorry. Here we go. Can you see my slides?
We can, yeah.
Sorry, I'm not on my usual location. Let me see if, does that look like
That looks perfect. That looks like it's in present
Slide. Okay, great.
presentation slide. Mhm.
And I'm going to apologize in advance. I'm not good at talking fast or using few words, but I'm going to do my best because I think probably everybody has questions already for the panelists. So as Henna said, I'm Manish Batra. I'm currently a professor of pediatrics and global health at the University of Washington School of Medicine and Seattle Children's. And I live kind of on the path in the middle of these two spaces. That's probably to those of you who have been in a NICU, in the minority world, the rich world, and those of you who've been in a neonatal unit in the majority world where resources are more scarce. And for those of you who do both, you maybe know what it feels like to jump from one to another to live a duality of plenty and of not. And I think for me, the reason I love this road is whether I'm looking at what's on the right or on the left, I see hope and I see opportunity. And so that's what's not on my CV, but that's sort of the world that I live in. And I was asked to sort of share a path to global health. And so I did this over the last couple of days. I've never been asked to share my path to global health before. So it was a little bit of a unique exercise. And I thought I'd start before as a disclaimer. Um, so this is me looking up a tree, and Hannah's heard this analogy because we meet a lot, and I only have a few analogies. So apologize, Hannah, but like if you imagine right now, if maybe you're at the beginning of your career or at a new beginning of your career, you're standing at the trunk of a tree looking up, and you might be wondering which branch am I gonna go out on? And you might not even know which first branch to take, but you see a leaf or a piece of fruit or a nest that you want to get to. And it seems like a very challenging thing to know which branch to go out on. Well, for the purposes of this conversation, well, in reality, I consider myself on the bottom of the tree still. I still don't know where I'm headed. I don't know what will come next. But for the purposes of this discussion, which is sort of a Manish, do your retrospective on your path, imagine I'm standing out at a nest way out there. It's the story I'm going to tell is going to sound like one way to get there because when you look down at the trunk, it looks very simple. It looks like there's only one way to get there. But when you're maybe considering what you're going to do, it's not as clear. And I guess I would just say you do your best at each branch point. Each one of those branches is another trunk. So you choose one and then look out the trunk and see which one you're going to take. So the retrospective on it is, and since we have a short amount of time, I move this slide to the beginning because if I've learned anything that I would want to share with you in my career, it's this. So typically when we think of what we do in medical care is we, at least in high resource settings, we treat diseases. That's what residency is. That's what fellowship is. You know, you learn to treat diseases. And maybe if you work in Seattle or Texas or Florida, you know, you have the list of diseases in a NICU that you take care of, or if you're on a pediatric ward, you have a list of diseases. And I think for a long time we thought that if you want to do global health work, you just change the diseases. You just kind of, instead of, you know, the diseases we see here, you start to focus on the diseases you see there. And yeah, it's a useful exercise. However, it's not enough. And it's a little bit, you know, if a ward is flooding with water, you know, and what's on the ground is water, and we have a mop, right? A little bit of treating disease is trying to keep it the water level from rising. That's what treating disease is. But what we really want to do is figure out why in the world is what's leaking or what's plugged. And why are we here mopping again and again and again? You know, your risk of dying from diarrheal disease, pneumonia, injury, malaria, measles is not created equal. not just where you get those diseases, but even within a place where where pneumonia, childhood pneumonia is rampant or diarrheal disease is rampant, your chance of dying is not equal for every child there. If you add in malnutrition or access to housing, lack of access to housing, your risk of death to diarrhea goes up. And if the malnutrition is the result of poverty or gender issues, or you're in a place of civil or natural disaster, your risk goes up even further. So if there's one thing I could leave you with that I've learned from looking up that tree a long time, is see how and when you can think about the intermediate or underlying causes of the problems you see when you care for patients. And I think our last speaker, Yasara, I mean, I think what you're doing on an advocacy level really, to me, is an example of that I hold as a role model. You start with what you see and you move to, ultimately it's governments, land tenures, status of the rich, and imperialism, and without sounding like overly evocative, it's true. And for those of you on this call who don't know about structural adjustment programs and neoliberalism, I highly suggest you Google it and learn, because starting to treat these diseases without understanding how we got here in the first place will start to feel like it's hard to hold meaning in the work, and to stay in the work. Uh, where did my path start? Well, and I'm going to stop soon, I promise. I graduated high school in 1990, so now you know my age. And my interest in health, I wouldn't say global health, but my path to health was the HIV epidemic. So when I was in high school, the first cases were being described, and it was terrifying. And the world's response was terrifying. I mean, I was young, and my prefrontal cortex wasn't fully developed, but I could tell the world we were getting this wrong. Like, what are we doing? All this fear mongering, politicizing this disease. And my interest really grew in this in college in the early 1990s. I graduated from college in 1994. And what I saw happening in the United States as I was going through college was like, oh, great, look at what's happened with HIV, the diagnosed cases per year, the deaths per year. I graduated, like I said, in college in 1994. And so we were over the hump, right? And the early 1990s, mid 1990s, the US, the fear went down. Everyone was like, oh, well, we can do more, you know. But when you zoom out, that's not where it was in the world. And the world wasn't done experiencing the ravage of HIV when the rest of the high income world had essentially moved on. So this was now like I finished medical school in 2000. Okay, so right around 2000. So what was happening in the world with HIV was really still very impactful to me. And when I was in medical school, that was it. I was gonna go work on this, and I actually started working on HIV when I was in medical school, and took a 5th year, graduated early, and spent 6 months working in an HIV ward in Zimbabwe. It was a very romantic time in my life where I went with literally went with a stethoscope and my medical school diploma. And you can't do this now. It wouldn't be safe because I didn't have a medical license. I didn't have insurance. And I just landed and I showed up and went to the hospital. I'm like, all right, get to work. And so that's what I did. I lived in a hostel and worked there. When I started residency, my motivation was to work in the majority world, and I didn't know how, what, or where. It wasn't called global health then; it was called international health. And I had all these different iterations of what I was going to do with my life over the course of the 3 long years of residency, and never imagined neonatology and global health. In fact, I hadn't even really done a neonatology rotation in earnest until my 2nd year residency. Didn't really know what it was. And it seemed like if you wanted to do neonatology, you'd studied sheep lung or rat brain. And that's what you did. That's what was happening around me, was clinical trials on those things. And I ended up going to a hospital in Uganda in 2002. Kind of serendipitously, I was looking for a place to move to work in malnutrition. I'd sort of landed on malnutrition as being where I was going to spend my time. And it was again through HIV and the relationship between HIV and malnutrition. And I ended up at this hospital in 2002. And it's where I learned that, half the world's deaths occur among newborns. The riskiest moment in the human existence, the highest age-adjusted risk of death in the human lifespan, aside from the moment you actually die. But if you look at it from an actuarial perspective, the riskiest moment in the entire human lifespan is the moment you're born. And I experienced that firsthand. That's me, Hannah. You probably won't even recognize me, circa 2002, literally unpacking and building a NICU. I mean, you see a patient behind me. That was what we built. And so this is still a hospital I work in. This is still work I do, as Hannah mentioned. And to try and get at the upstream from that first slide I showed you, I spend much more of my time now on the policy and governance and the WHO and multinational side of things for newborns. But this is where it started for me. And this has been, that was a little bit more recent. We've done lots of work together. That's my colleague, Dr. James Nyonyentono, who's still at Chiwoko. We started this work together. And what I think maybe I'm actually going to stop because we have only 2 minutes left, but I have lots of other slides that I'd love to share another time, and you can contact me if you're interested. Sorry for rushing through so fast through that.
No worries. This is like, I feel like we should just have like a NICU Global Health Retreat day and just get together and talk a bunch because there's clearly so much to chat about. So thank you for sharing all of that. Manish, I know you have to go in 1 minute. So I don't want to pressure you to stay at all any longer, but I know Teresa and Yasser have some availability to stay on the line for folks who have questions. And Manish, if you're willing to put your email in the chat in case people have questions for you. Um, And it looks like Sarah has put a question in the chat. Thanks for that, Sarah. So given visa-related travel restrictions, how can someone contribute meaningfully to global health work virtually?
Anyway,
I
yeah.
guess oh, sorry, go ahead.
No, I mean, I guess it's that there are many ways, and I mean, one of the ways is probably education. So, obviously, and I think it still is important to go to whatever you are doing the education or something, because sometimes you identify things that you will not imagine. But I think it's a way to, I mean, education and also, I mean, Sarah, here for a while we have I didn't talk about Haiti, but this is a very complicated country. So everybody, I mean, like Africa and other countries sound like but Haiti is right here and it's very complicated. So for example, for many years we have rounds and I think it was on Wednesday, was Dr. Sosenko who was doing it. And then now you have sometimes rounds with other institutions, and that's a way to contribute. I think the most important thing of those things is to be persistent, to plan, to have a plan that you know you can maintain. That is not one time, but just to be persistent.
Yeah, I think that's great. I know at CHOP they have like virtual rounds with a couple hospitals, including one hospital in I believe in Laos. Um, and so their residents will present cases, and then I think they alternate which group presents cases. And we did that in the Dominican Republic with a hospital in Texas as well. So I think that is a great model. And I think there are also kind of groups springing up that are, I know, like Partners in Health and some other groups are looking for people to lead sessions virtually as well. But I think that's a great point. I think given visa-related travel restrictions, given kind of what we learned from COVID about the benefits of virtual engagement as well. And in a way, it's nice because you don't have to, to state the obvious, you don't have to um, go down the airfare route. You know, you don't have to pay for air travel. You don't have to take on the environmental impact of air travel, and you can make it just a little bit more regular and sustainable. You can do a virtual meeting monthly, whereas you might not be able to travel monthly, for example.
Yeah, no, thank you for that. No, I do like in Pakistan, I do take like virtual sessions for trainees over there, but it's just that the terrain and the area, like they don't have like stable internet connection as well. So I think that's just, although like virtual is a good option, but I don't think it's applicable everywhere. And till you're not there in the field, I think it's really hard to build that trust amongst the local communities as well. So I just feel like that's something that, yeah, I'm still figuring out.
Yeah, I want to ask you, Yasser, because I think that, I mean, whatever you describe is a very special situation. And I think, but at the same time, whenever you do global health, the feeling that you are trained as a neonatologist, or maybe you know how to do very sophisticated things in the field of neonatology, and then you get to a place where you want to help, and you, I mean, it have happened to me also, like you don't remember your pediatrics, so whatever you can, I mean, the way that you can help is not whatever your expertise is. So how do you think, I mean, I think it's something that everybody who is involved in global health had to assume in some way, but can you comment on that?
Yeah, you know, within 24 hours, I realized that medicine, like the actual practice of medicine, was going to be the least helpful thing that I could do, to be quite honest. I think it sort of talked, you know, getting to what Manish was saying about the big picture and really being of like the power that we have coming from America, to be quite honest, and coming from Britain or some Western country, unfortunately, because of the way that the world is developed and the way that, you know, the perceptions matter, like our voice can impact people abroad by being loud sort of domestically. So like for me, I realized quickly when I was in Gaza that I just needed to document, and report back my findings to those that can potentially change things. Like that eventually became my mission over there. And it was about that's one aspect. Then there's like the emotional aspect was just being a comforting person for people that felt like that the world had turned their back on them. You know, there's no independent journal. I know it's a very unique situation, like you mentioned, but like there were no independent journalists that were going into Gaza outside of the Palestinians themselves. So no, like the doctors were the only people bringing in supplies, the only people that were able to objectively from an outside country document what was happening, and then coming back to report domestically. Like you're not going to see these reports on CNN or Fox News or anywhere else. And so I realized like my time and energy needed to be spent there. And then the other thing is interesting, you know, when I came back and I spoke to medical students who wanted me to talk about my experience, you know, some of them were so passionate and they're like, you know, I'm going to quit medical school right now and I'm just going to go do political advocacy work and I'm going to go abroad and I'm going to do XYZ. And I'm like, no, finish medical school, even if you don't plan on practicing medicine, because those two letters behind your name will carry your voice further. Um, and so it's just woke my eyes up in terms of how the world works. You know, uh, I don't think I'll ever be the same person again, and I don't think I'll see the world in the same way because you realize like the things that the impact that you think that you're gonna have doing global health work can be you sometimes realize that the energy can be best spent on the preventative aspect more than anything. And the preventative aspect is not just medicine, it's political and the politics of global health. You know, you realize how intertwined everything is. And it's not about getting X supplies to this NICU. It's not about that. It's about the 100 steps before that of what's causing any crisis, or so to speak.
Right. Thank you.
That is super, yeah, that's super helpful to hear. And I think really important to remember. And I guess it leads me to one of the questions that maybe I have struggled with a lot in my like global health work, which is just like knowing everything that you just said, Yasser. Like it's not, like giving a band-aid to the kid in front of you is important, but it's not going to mean that that kid doesn't have that same wound again, it doesn't fix the underlying issue. And so I guess I'm wondering what keeps you both inspired, energized, motivated when it's hard work and you're seeing a lot, you're just up against a lot. What keeps you going?
You first or me first?
You first.
Me first. Well, I don't know, but I don't. I think it's the same thing. Like, I mean, you see the changes. I think um, you, I mean, you foresee that there is something that can be changed, and you foresee that not only you but everybody can contribute. And then at the end, I mean, there are many stories that they put together. I mean, one side is the numbers, so and this is something like is probably a challenge in global health. So whenever you present statistics and things like the mortality has decreased and everything, and it's a challenge because sometimes you cannot collect those data, you cannot do the strict research that you will do in the States. But so that side is one side that you sometimes you don't see the columns and the decrease of the numbers. But and the other part is that there's to go back and to see how things are changing and to see individual stories like individual families, individual success, individual things. And I think it's something like yeah, it's part of your life now. So
Yeah, to build on what Teresa said, it's like for me, it's like we have such a short amount of time in this world. And I'm a person like I believe in God. And so I know not everybody does, but like ultimately for me, it's like did I do everything I could? Like the outcome is not in my hands. But my effort is. And so that's what keeps me going. Is like even if whether it's like being at a protest or raising my voice or like going abroad, like did I do everything I could with my time to help those that I could potentially help? And whether or not I help them, with what I do, I don't know. But if what I do results in one life saved over 10 years, like that's worth it to me. So.
yeah, and I think I mean just started at the beginning saying, I mean when he questioned what is he doing, I mean do I have to do something? I mean, I have a good life, I have a lot of resources, I have many things that the rest of the people or many other people in the world they can't. And then you see like you see it's very rewarding, like a little drop of something that will not have any impact in a different world. It does have an impact in those areas.
Exactly.
Thank you so much for that. Yeah. Yeah. Um, does anyone else who's on have any questions? Or I know yeah, Michelle, Grace, God bless, Shanique, Shannon. No worries if not. I have some other questions I can ask, but if you do, please feel free to pipe in.
I just want to congratulate the group because I think this is a great initiative. And I think, and also it's a good way to, I mean, to discuss things with other people, to learn from other people. And I just encourage you to continue to do this.
Thank you.
I do have a question. I don't really, I guess, know exactly who it's for. Maybe you, Henna, or even for God Bless. Just, I guess, for people that have been have worked in one NICU for a more prolonged period of time. Anyone really on this chat, but I've been going back to Tanzania and doing like more short-term teaching of like very hard skills, clinical skills. But then I leave, right? Like I come home. So as I come back this year, I'm just trying to think about how to best maybe like introduce education or work with nurses on teaching them how to structure like a project, a quality improvement project in their unit, or just like that type of teaching, that type of learning, because I think that is really what will create sustainable change after, like we come and we teach and we leave. I want them to learn how to like identify issues like that, structure a project, champion a project, and then teach their other medical staff to do the same. So I just don't know if you have any experience, or like, God
Yeah,
bless you saw that in when like Erin and Lisa worked in the unit in Arusha, but or even Teresa Yasser, just
yeah,
anyone, but something like that.
yeah. It's really, I mean, really the thing is it represents a change of culture, and a change of culture doesn't happen in 3 days or 2 months.
Right.
And I think the technology now and the easy communication can help a lot in that regards. What you are telling me, it reminds me, you said you work in Tanzania. Yeah, so I have a niece which is a pediatrician, so went to Kenya, and then she got all kind of slides and lectures and everything to teach people natal resuscitation, same thing. And then she was every Wednesday that she was planning to do that, she was texting me frustrated, like nobody show up, nobody show up. They are all busy, they are whatever. And obviously that's a challenge and sometimes it's frustrating. But I mean, there is ways. So in Dominican Republic, we have, I mean, if I go to my WhatsApp chat, and now everybody has a phone. No one, I mean, some people doesn't have a car, but they have a phone. And we have a bunch of chats. One is the kangaroo care, one is the nurses of the West, one is whatever. And for example, one example is that 2 or 3 years ago, there was an area of in the West, in the East of Dominica, close to the La Romana, where we went to two hospitals, and there were nurses interested in starting an education plan for the nurses. So what they were doing, they were putting in the phone, like in the WhatsApp chat, like statements, like or questions. So the people was answering. So the people was already having the question in their mind, and after like 2 or 3 days of questions or comments or something, there was the educational activity. So the Zoom for presentation of that case or that topic or that thing. And it was really well attended. I mean, it wasn't a small group, but really after 2 years of doing that, it was very, I mean, there was a change. And also we did surveys before and after, and it was a change. And then the chat was open also for them to ask questions like, this is happening, what do you do, what will you do, what I should do, and things like that. So it was a constant communication. That is one of the things that worked for that group. Doesn't mean it's going to work anywhere, everywhere,
Yeah.
because that's the other thing of the global health, that whatever works in one area, it may not work in the other area.
Yeah, for sure.
I think too, yeah, like thinking about like change in practices and things like this. I think this one of our previous panels, Scott Guthrie, who Shannon and God bless you both know, and has also worked in Tanzania. He was, he was like this idea of change being slow and working hard to keep people engaged isn't like unique to, as Manish, I like Manish's term about the majority world, right? It happens here, like it happens everywhere, and it's something that we're familiar with here as well. I think I don't know, one of my favorite things that I've been learning about, I'm doing work in respectful maternal and newborn care. And so there's like data on how often babies are like held upside down for resuscitation, or kind of like held upside down and slapped. But that, like that was a practice that came from the good old US in like the 50s and 60s, and so that was a practice that was changed here. And I think like similar slow steps can happen around the world. And I love this, like I mean, WhatsApp makes things so approachable. I know like I feel like I still see chats on the Tiny Feet Big Steps, which is the conference in Tanzania, chat going through. And yeah, I think it can be challenging because I think we're like it's like being brought up in the US and then being brought up in the healthcare system where we're like, okay, got my checkbox, gotta like move down the checklist and like check the things off. And I think that um it's humbling to remember that that's not how things work in a lot of the rest of the world. And like, you know, to like, I don't know, I would always joke that like in the Dominican Republic, Teresa and I were just chatting about this, like meetings would start like a half hour, 45 minutes later, because instead of going through your check boxes, you were like catching up on each other's families. And I think there's benefit to that too, you know? Um, yeah. So I don't know if I'm answering your question at all, but just some thoughts about it.
Thank you.
Incentives is something that always work, even if it, and then sometimes, I mean, what she said that it's not, it happened everywhere. So sometimes here in Miami for the nurses, I wanted to implement something and I had gone and did the speech and whenever they have a good response, give a chocolate. So, but it's a positive reinforcement. So.
And simple, just a little chocolate, but everyone likes chocolate, as far as I know. Any other questions that folks have? Or God bless, did you have anything to add? Sorry that I.
Hi. So a little bit, and I also had a question, but just to contribute on the previous question, I think the thing that most of the low resource country usually would benefit from is like, you know, people who are coming to do global health and everything. They don't come with their ideas. They at least try to learn what's actually needed because you might be passionate about something A, but something A is not what actually the people need. They actually need something B. So if you're able to, you know, give talk what they need, they'll usually become a little bit more interested. Plus the other thing that it takes a little bit of time for people to trust and like accept and you to establish relationship, which that is also one of my question. You know, being US based and everything, how do you work around that to establish consistent relationship? Because you know, consistent relationship does not mean coming for 1 week in a year. It means like, you know, be there most of the time and everything, and then also being able to keep like your job and like your, you know, salary in US and everything. How do you work around it? Because if you're able to get that consistent good relationship and rapport and everything, it actually makes the work easier and more impactful rather than just like working in like, let's say 10 or 15 hospitals. Sometimes it might be a little bit difficult to see the impact of the work. So that was the question from like the previous speaker, like on the experience, how are they able to at least establish that consistent relationship?
Yeah. Okay, so if you ask me, one of the things that makes it easier here is that, I mean, it's relatively close. So you go to Dominican Republic, it's 2 hours, and so it's relatively close. So the relationship is not only us going to Dominican Republic, but it's also that we have had people from Dominican Republic coming to visit the hospital or to spend some time with us. I understand completely what you say, just going once a year or one time. It doesn't, I mean, probably doesn't make the feeling of something that is part of the system. So for other far countries, I don't know. I mean, it made me remember that there is Doctor Without Borders, and Doctor Without Borders. They one of the conditions is that you want to do something within. It has to be at minimum 2 months. And then related with Yasar put in one of the slides that I take vacation to go. There is something is called Doctor Without Vacation, which is your vacation because then they allow you to go 1 month to whatever you want to do. So I think this kind of experience that you go for a short period of time or anything, something like that, is very inspirational for the person who goes. It's but at the end it's just one experience isolated experience. But you are absolutely right. So the thing you had to maintain the relationship. Again, I said the phone and the easy communication now, the easier communication now for everybody, it may help a little bit, but that's why it's probably also important to be part of a group or a team that you, somebody can go and you are acknowledged like at the team. So this is the team that is coming to do this and to do the other thing. And probably to facilitate the interaction, like I'm going and they are coming, also helps a lot. In that sense, Europe, they have the European community, they have grants that unfortunately we cannot, as an American, can apply for that. But the grant, I just got the alert last week, is for exchange of people. So it's for people to go and for people to come. It's for a period of 2 years and facilitate the exchange in all the levels. So I was involved with the implementation of family integrated care, which is the parent being more part of the care of the newborns. And they have all kind of people from Europe going to Africa, people from Africa going to Europe and to other countries. So I think that facilitates to maintain the relationship.
That's super helpful. Thank you. Lots of good ideas. God bless. I'm curious if from your end, like working in Tanzania, if you have any thoughts about what's been helpful in from like as people have come from abroad in terms of building that trust and building that partnership, what sorts of things that people have done that have left you feeling like more like it is a relationship that you value and want to continue. And yeah, curious if you have thoughts about that.
In the when you have a visitor coming to the hospital and teach and everything, so the first impression is usually you're a little bit apprehensive, and
Mm.
you're like, are they trying to bring US or European way into Tanzanian way? And we know that that's not going to work. Are they just here to do like the medical tourism and everything? So people, they're usually not that much open in the beginning until they can feel comfortable and they can know that you have actually their interest at heart, which takes a little bit of time. And I would say one thing that have been helpful, looking back in my 4 years working the NICU at LMC, it has been the knowledge impact. So it has never been, when I started my work as a registrar, I worked with Kendra for 5 months. She was doing global health chief elective. And it has never been about, buying US equipment and ship them and like try to improve healthcare by using them. It has more been that what do we have and how can we improvise and mimic what it's supposed to be done in terms of like things like blood exchange transfusion, things like chest tube, which you use just like, improvise using the saline drip and everything. So, and through all those innovation, through those improvisation, it has been it was kind of combined knowledge. It was, a Tanzanian physician, like a person who is there in Tanzania, plus the US person sit down and figure out how can we make it work? How can we make it work? Also, like the thing like which we do in our NICU, which is sodium supplementation. We use normal table sodium. But that is, you take the US NICU guideline protocol and everything, and they're like, okay, how can I make it work in Arusha and be beneficial in Arusha or in a resource limiting setting. So I think one of the things that has made a lot of impact, it has been that, someone from research rich setting come in with the knowledge, which, you have, you're privileged to have like good healthcare, good quality healthcare with like bunch of knowledge and bunch of research-based evidence, and then try to see how can he or she put it to work in a Tanzanian setting. I think that has been the most impactful thing. You know, Shannon was saying about quality improvement project. It's if, let's say, for example, someone comes in Tanzania per se and then says something like, I want to do quality improvement project. When you use the word quality improvement, people, they won't really understand it because that has never been in the culture. It was not in our medical training or anything. People, they might not be that much receptive about it. But if, let's say, you just stay with them for like a week and you're like, okay, I noticed that maybe something like infection prevention or something like this is not working well. Okay, let us take 2 or 3 nurses, Tanzanian nurses, and then work with them and everything. And then they see the change that, the process to go through that change and see the impact of the change, and then at least facilitate them to recognizing problem and how to work around them and how to bring small changes in the NICU, which is like technically they're doing quality improvement, but they don't know that they're doing quality improvement. I think that might be the way to go around it. Sorry if I went in a little bit of a tangent, but thank you very much.
No, that was super, yeah, that was great to hear. God bless. Thank you for sharing that. I think kind of some of the themes that we've heard from you and from the panelists for making sure that your priorities align, not going in and saying, I'm gonna bring like, a talk on ventilating babies when like that is likely not what people need, and kind of cluing into what people need in the place where you're going. Yeah, no, it's super helpful. Thank you. God bless. Any other questions that folks have? Any other closing thoughts or and Teresa, I'm wondering if you're willing to put your email address in the chat also in case folks want to contact you afterwards. And I'm happy, I'll put my email also in case anyone wants to contact me, and I can connect you with any of our panelists as well. But I know this was so inspiring and amazing that we went way over. So thank you all for staying on. Yeah, and hopefully if, reach out to me if you want to be connected with anyone. Hopefully we can form some good connections to inspire each other and stay fueled in this work.
Thank you.
Thank you.
And
Good to
very
meet.
nice to meet all of you. I have my email is there.
Oh, I think it was just a direct message to me, so I'll just copy and paste it to everyone.
Okay.
There we go.
Yeah. Okay.
Perfect. Good to meet everyone, and good to see you, Shannon, and God bless.
Thank you. Great job.
Thank you. Thank you very much.
Thank you.
Bye.